What you're describing is our phase 3 clinical trials, but there are a number of clinical trials which are phase 1 and phase 2. It's important to understand the difference. The phase 1 clinical trials, we don't know if the drug works, and we don't know what the toxicity is. And so you're more of a guinea pig in that case. We may know more or less about certain ones. But all of the promising therapies that we use in multiple myeloma, patients first got them as phase 1 trials. In phase 2 trials, we generally know that the drug works, but we don't know the best way to use it. And so, and you can get some of the most exciting drugs in phase 2 trials, and there's no placebo. And the other thing is that even the phase 3 studies, most of them don't even use a placebo. They use what we call standard therapy, or what the doctor would do if they didn't have whatever the new treatment was. So there's very few placebos.
Maybe I can expand a little bit on that, because in medical practice, and this is such an important point, in medical practice, first of all, it's considered unethical to use a placebo just because of using a placebo. So no one would ever do that. And when you do that, you only do that with a patient consent, and it's like in one of those trials. So let me use an example of clinical trials that have been reported. The ASPIRE trial that looked at carfilzomib, Revlimid, and dexamethasone versus Revlimid and dexamethasone was not placebo controlled, because placebo there would mean the patients would have to come in and get injections of water. Like, who wants to be driving for that? It's kind of a very hard sell, if you may. Now, on the other hand, the tourmaline study. So the tourmaline study compared Revlimid, dexamethasone, ixazomib versus Revlimid, dexamethasone, and placebo, because now you can give a sugar tablet to someone without knowing. Now, patients will always know. They say, you're going to participate in this trial, and we would always tell patients, your participation in trials is completely voluntary. We'll care for you as well. We'll love you as much whether you participate or not, but it gives you options. So that's how the Nilara was approved through the phase 3 clinical trial. But at any given time, if anyone was ever in the setting of clinical trials, as Dr. Bergsagel say, placebos are only used in phase 3, you would know also. You get these consent forms that are longer than a mortgage application now, which some have argued are even hard to understand, but that's where they would do that.
It doesn't, when it comes to, the reason why we call somebody active myeloma is because they have some reason to get started on treatment. Sometimes it doesn't quite fit the bill, but if that underlying process, in which in your case is the smoldering myeloma, is causing clinical symptoms as caused by cryoglobulinemia, and if that's getting worse, that would need treatment. Again, without knowing in depth about where you are with your symptoms and so forth. But if it is a bothersome symptom, then that is reason enough to get somebody started on treatment. You don't have to call them active myeloma per se, but it's still something that is, treatment is needed.
And is that something that you treat here at Mayo?
Yeah, that would be something that we treat here. But I think when we start treating smoldering multiple myeloma, I think we generally, or the symptoms that are associated with it, we generally treat as though the patient has multiple myeloma. And we don't usually say just use a low dose of prednisone to deal with it in most cases.
There's an important distinction, I guess, going to your question, that when we think about myeloma, what we really are saying is there's a cancer behavior to those cells. So the cells have reached a point that they're compromising your bone marrow function, or they're destroying bone. So that's when we talk about myeloma. Now, there's other situations where you may start treatment when the cells maybe are not that aggressive, but they still cause problems, and cryoglobulinemia would be one of those examples. Another example would be patients who have amyloidosis. So they don't have bone destruction, they don't have necessarily anemia, but they have a protein that's creating problems, which is exactly the same thing with cryo, and that's why the tools are the same. But one of the very, very important distinctions is when you're treating myeloma, you're facing an aggressive opponent. So what we're normally doing, induction, transplant, maintenance, when we treat things like cryo or amyloidosis, we're usually treating kind of indolent cells in the background, just that they produce bad proteins that one way or another compromise the person's body in some way or another. So the treatments can be usually of a shorter duration of length, as opposed to myeloma that I always say, once you treat myeloma, you cross the Rubicon. So you go with the full intent of trying to keep it under control.
I assume that you are familiar with the removal of the T cells, manipulating them, putting them back in your body. I know Dr. Stewart wanted to put me on that trial, first phase, felt that there was some promise. They only took 3, I was 5. And then I found out that some people had died from that. What was the cause, or do you know what was the cause in that deaths?
So I know we're going to have a session on CAR T cells, so we can expand a little bit. You're doing the CAR T cells, right? But sometimes when you unleash the immunity, it's a big deal, because that's our own immunity can be quite dangerous, and that's what happens. So there's a number of things that can happen. One of the things is like a super immune reaction. We call it CRS, for cytokine release syndrome. So it means that the body is just having a massive inflammatory state. In fact, when people, we all get our flu shots. When people die of influenza, usually they die because of inflammation, because the lungs get so inflamed that you cannot exchange air. So that's kind of a similar thing that happens, but at this level, it's at the whole body. And then there's some neurotoxicity that has happened, meaning that sometimes people have gotten confused, sometimes even, extreme cases go into coma has occurred with the cells. Now, there's a much better understanding of this, and I guess the good news, a lot of this is being played out, because this is the first foray in that whole field. I anticipate that within the next 2 years or so, as we learn more and we're learning about the drugs that prevent some of this will be safer.
Thank you.
Yeah, there's been a lot of studies have done, and there may be a slight survival advantage, overall survival advantage to transplant, but it's not a huge one. The biggest difference is that if you don't do the transplant right away, your disease will relapse sooner, and you will have an earlier relapse, and you will start other therapies sooner. And the patients where they show the survival of the same, both arms get transplant. It's just in one arm they get it right at the beginning, the other arm you get it later. And if you're going to get a transplant either way, why not get it at the beginning when it works the best?
Because age could also be a factor with the other,
Yep. Those studies that I showed you was done in Europe, and they didn't transplant anyone over the age of 65.
So the reason why we probably don't use it as much as some of the other drugs is it does come with a lot of side effects, a little bit more than what we see with the other commonly used myeloma drugs. And the second factor is, again, the amount of benefit that drug has provided in the clinical trials isn't of the same magnitude as some of the more exciting ones like the monoclonal antibodies and other drugs that kind of came around at the same time. So it's part of it is the timing when it came out, and we had better things at the same time. And part of it is just making sure you manage the side effects. And then the third thing is the only place where it really has shown benefit is it in combination with the proteasome inhibitor class of drugs. And the main trial that led to its approval was in combination with bortezomib or Velcade.
Well, I guess that means I'm an optimist. But no, my opinion or my view of a cure is that we treat you for a defined period of time, and then we would stop. Where something like the CAR T cells that we heard you, where your body's immune system has been turned on in a way that it can control the disease, or that we've managed to eradicate everything that was there at the beginning by combining all these different drugs in the right way. But it probably won't happen by 2020. Or if it does, we won't know it.
To some extent, again, there's some philosophy and some fact, right, when you talk about cure. And myeloma being something that, again, the average age being 67 years, right? So the question is if you can keep the myeloma under control for next 20 years, it could essentially mean cure for somebody who is 70, but for somebody who is 40, it doesn't quite get there. So I think, ideally, when you say cure, you mean you can't find any myeloma cell and you're not on any treatment. That would be the state we would like to be at some point, 2030 or whenever it is.
A lot of this is philosophical. If you read any paper or any chapter, the first sentence is going to say myeloma is a plasma cell tumor that is mostly incurable, right? And actually, I sit on the camp of that we can't really accept that anymore. We have to be more optimistic. And I'll show some data in the afternoon. We already cure some myeloma patients. So there's a fraction of patients that are cured. It's a very small fraction still, but there's a fraction of patients that go through transplant, sometimes through maintenance, and will never again require what we call quote-unquote intensive treatment. So that can happen. We want that to happen for everyone, but it happens for a small fraction of patients. So some patients are cured from their myeloma. Last week you saw a patient who's 11 years out from a transplant with not a blip of proteins or anything else, so we just mostly talk politics when he comes to my office. That's what we do. So, so there are some patients that can be cured. Now, I think that fraction is increasing, as Dr. Bergsagel says. We don't know, because it's until you have a track record that you prove that more people are staying there. But we probably are getting closer and closer to more patients being able to be in that category of very long remissions and what we would call a cure.
Funny, I saw a patient this week who got a transplant in 2005, hasn't received any treatment since the day of the transplant. But she's had an M spike, the whole time. She didn't get MRD negative. She didn't get a complete response. She had a partial response, but never required any more treatment. Well, that's a little hard to say. The role of the steroids is interesting in multiple myeloma, and maybe I'll address that aspect of the question. The steroids probably don't cause neuropathy, so I'm not sure why you stop them because of neuropathy. They do have a lot of other side effects. They can be hard on the bone and cause osteoporosis. They can cause mood swings and weight gain, and you probably know the side effects better than I do. And it's amazing that dexamethasone is almost always included with every single drug regimen we use. Why doesn't the myeloma cell become resistant to dexamethasone the way it does to everything else that we use? But it's every time it's been looked at that we always seem to get a better myeloma response when we have dexamethasone there. And so I don't know the answer. My personal theory is that the dexamethasone is targeting not the tumor cell, but it's targeting the host and the host factors that support the tumor cell. And that's why resistance doesn't develop, because the host doesn't have mutations and get resistance. And so it's possible that the dex was helping the venetoclax to keep your M spike down, and that by stopping it, that it went up. That's my opinion.
So I'll let the mutation question back to you, but let me first talk about a couple of things. One is the multiple transplant question. So clearly, from what you saw earlier in the morning, the transplant still plays a major role in controlling the disease, and we all think patients who are eligible to get a transplant should be considered for that. Now, the question that comes up is, we always collect for more than one transplant. And the reason we do that is either because we want to use them back to back like a tandem transplant, or else we can use the other one later on when the myeloma comes back, maybe not as the second treatment, but maybe as a fourth or fifth. And they all have their own unique roles to play. So the tandem transplant, at least from what we have known from the recent studies, specifically seems to have some benefit for patients with high-risk abnormalities. So patients with translocation 414, 17p deletion, those patients appear to have a clear benefit from getting a tandem transplant compared to a single auto transplant. So I think most of the use in the tandem transplant, at least in the US setting, seems to be for those patients. In Europe, it's much more widely used, tandem transplant, as part of routine approach in many institutions. The use of the third transplant or the second transplant, whichever comes at the time when the myeloma comes back, can be quite useful. If someone has maybe, let's say, 5 years that the patient has had the myeloma stay away from the first transplant, then doing a transplant at the time when myeloma comes back can be quite beneficial. Because even though the second time the disease may stay for shorter than the first time, depending upon how much benefit they got the first time, you can have, can put it to good use.
Is that with or without treatment, though, during that interval? Was the patient receiving?
Maintenance or not?
Right.
Yeah. Either way, if the maintenance, we started using it more routinely in the past 3-4 years. So I think what we can tell with relatively good certainty is that if without maintenance, if the transplant only holds the myeloma for less than a year, there's really no point in doing one more transplant. And with maintenance, if it holds it down for less than 2 years, then it's probably no point in doing the second transplant for relapsed myeloma. But one other common situation we run into often is that as we have more and more drugs and patients get 5-6 different types of drugs, their bone marrow kind of starts petering out because they just don't have the reserve anymore. That is a time when doing a second transplant with the cells that have been stored from before can reset the bone marrow so that now you can actually get treatments that are available today, which otherwise the patient couldn't have, or maybe even not be able to go on clinical trials because the blood counts are relatively low.
How long can you keep those cells in storage?
Forever, as far as we know. I mean, we have used it for 15 plus years later too. So
I'll tell you about the mutations. So the drug that we use in transplant is melphalan, and that is a drug that damages DNA. So there is a concern that it could introduce mutations into the tumor and into the host. There is a low rate of leukemia and myelodysplastic syndrome after transplant, but obviously we think that very low rate is much less than the risk of not treating the myeloma effectively. And for the vast majority of patients, the tumors, we don't know that we're introducing harmful mutations with the transplant. There may be some patients, but we don't know who they are. And so there is the concern, but the sort of clinical practice is based on what we've shown has worked in patients. And so we have it in the back of our mind, but we go ahead with it.
Just quickly answer to your first thing about the amyloid and the myeloma coexistent, right? So it's not very common. We know that sometimes patients can develop amyloidosis after years of having myeloma. And again, not very common. Now, one crucial distinction is sometimes we say myeloma and amyloidosis just because there's more than 10% plasma cells in the bone marrow, but not because they have bone disease or kidney problems or any of those things we typically associate with myeloma. That is a little bit different than when somebody actually have bone disease and also have amyloid involving the organ. In general, the treatment approaches are similar, except that when patients also have organ involvement with amyloid, there are some drugs which they don't tolerate very well. Like Revlimid, for example, they may not be able to tolerate the full dose of Revlimid. We often decrease it down to 5 or 10 milligrams instead of the 25 milligrams, especially in somebody with heart involvement with amyloid. So there are some tweaking of treatment that we end up doing for patients with amyloid and myeloma. But I think in general, the drugs that we use are similar.
Are you still concerned about the percentage of plasma cells that someone is diagnosed with initially, determining their outcome?
Yes, we know. We know that patients with amyloidosis with more than 10% plasma cells have probably a worse outcome than people with less than 10% plasma cells. And we believe that especially the ones with more than 10% plasma cells may have all the more reason to get a transplant-based treatment in the beginning compared to not a transplant.
Any difference between the dose of 140 and 200?
If you cannot use 140, might as well not do the if you cannot use the 200, might as well not do the transplant is what we have increasingly becoming, sure of. So if you're thinking of using 140 because the person has, is not in a very good shape, then don't do transplant, do the non-transplant type of treatments. But if the reason for using the 140 is because the kidney function is low, that's okay. But if it's because the performance status isn't good, then you should really be thinking about non-transplant treatments. And this is something that I think we are understanding more and more in more recent past.
One of the things, I'm going to say a little bit something controversial, but one of the things is amyloidosis patients, and there's other in the audience, others that are dealing with this. That previous comment that I made with the cryo, oftentimes the cells are quiet, and so we do a bone marrow, it's 5 to 10% plasma cells, but just the cells produce a bad protein, a sticky protein. A protein, I call them like stacking chairs, they kind of recognize each other, and that's what creates the amyloid deposits. So one of the things we've done a lot more now is we've treated a lot more patients with other treatments before they go to transplant. So still we use a lot of this treatment, the so-called CyBorD for amyloidosis. And I have to tell you, this is the controversial part, I scratch my head as to whether transplant adds anything else after that point. And the reason being is because in myeloma, for me, in 2017, still we're big advocates for that. But in amyloidosis, there's two things. First of all, the mortality of transplant is higher in amyloidosis. Even in the best centers, it could be 2, 3%, 4%. Let's say 3%. That's 1 in 30 patients. That's a pretty high number. And it's a more toxic process. And number two, if someone already has a complete response and had a small clone, I really question the incremental benefit of the transplant. So the standard answer is transplant is there, but I think a lot of people are asking those questions too.
When to do the bone marrow biopsies at what intervals throughout treatment?
Well, it's a little bit, I have a friend who's a hypochondriac who tells me I'm not comfortable unless I get a daily CT scan, right? So it's the same thing with the bone marrow. We want to avoid them because there's a discomfort, and we probably will do them at the time of a major change in someone who has previous therapy, but not always. Sometimes, we know that even no matter what, there might be a next step that is the best next thing for the person, so the bone marrow wouldn't add much. And when we test for subsequent bone marrows, we're testing for the progression events that we call the mutations. Now, one of the things we're doing here, and this is with the support from Dr. Stewart, who's not here today, if we have someone who has more advanced disease, we do two things. First of all, we have implemented through the clinical practice mutation detection. So we do a mutation panel. So we look for things like the BRAF and other mutations to see if there's something we can learn from that. But the second thing is we put the cells in little wells in these plates that are exposed to many FDA-approved drugs that we wouldn't think about, maybe drugs that are being used for kidney cancer. So we bring the mutation and we bring the functional testing together. Well, I think there's multiple situations like yours when someone had a transplant in the past and there was kind of a whole gradient of how maintenance was being integrated. I think the final step was a meeting that occurred in May of this year where they showed a very large study. So I think even the most conservative person with treatment would now have to say maintenance is the standard. But if you already had your transplant, you didn't have a maintenance like the patient I shared with you before, we kind of go through that conversation. You can start it, but more often than not, we have just continued to monitor the person. But a lot of that depends on the risk factors, the genetics, where you are, how much time has elapsed since the transplant. And that's why some people were waiting, because they were saying, well, I have a patient who's been 7 years out from transplant, no maintenance, and is doing very well. The way we flipped that question is, if I knew nothing else, and in 2017, I did a transplant on a patient, I know that if I take 100 patients here that go on maintenance and 100 patients that don't go on maintenance, there's a huge difference on how much time passes until the time they need next treatment. With maintenance, it's approximately a little bit over 50 months, so almost getting close to the 5 years. With no maintenance, it's about 2 years.